Top Med Talk.
Hello, welcome to Top Med Talk. I'm Andy Cumpstey and I'm here at the Evidence-Based Perioperative Medicine World Congress, that's EBPOM 2025, and it's great to be back here in London, in many ways the home of Top Med Talk here in the United Kingdom, where it all came from, at the final day, sadly, of another really fantastic 3 days of EBPOM. And I'm delighted to be joined by who may be a familiar voice to many of you on Top Med Talk, but it's great to have you back. Welcome back, Simon. Will you give an introduction to yourself?
Excellent. Thanks, Andy. And great to finally meet you. So I've passed you at many conferences over the years, but never really met you properly. So it's a real joy. My name's Simon Davies, and I'm an anaesthetist by trade. I moved to university life about 3 years ago. So I now split my time half university, half NHS. But also over the last decade, I've worked with various industries around the monitoring sphere. So BD, formerly Edwards Life Sciences, and also some startup companies in the US as well. Monitoring, I guess, is my interest, and lots of my research has been around that. And I use it in day-to-day practice. So interested from both a personal and practical perspective.
Brilliant. Well, thank you very much again for joining us back here on Top Med Talk. And like you say, great to meet you in person too. We've crossed paths lots on the way. We've never spoken like this before. I've got to ask, what have you enjoyed most about the last 3 days at EBPOM?
I enjoy it for different reasons. The networking and meeting people is brilliant. The scientific context is excellent, diverse, not always at things that I'm actually interested in. But the highlight for me was Maxime Caniston's plenary lecture, which was absolutely superb. A journey through physiology, starting in the Egyptian times. Any talk that opens with a mention of Imitap is going to be on a winning basis. And he took that all the way through to modern times, and it was delivered with real passion and sophistication. I just thoroughly enjoyed it. It's on the Top Med or on the EBPOM website, isn't it? So anyone listening who's not actually at the conference, please try and listen to Maxime's lecture. It was absolutely fantastic. I'd recommend it to anybody.
So I guess we should talk about what you've been up to recently. You've just been on some exciting travels, haven't you, over to the States?
Yeah, so I go to and from the States a fair bit just for research and for industry. And a month or two ago, I was in San Diego doing a bit of work. And Monty Mython, everyone knows, who's now SVP for Becton Dixon and patient monitoring, said, well, listen, we're having a briefing at Capitol Hill. Do you want to come along and observe this, have a chat with people? Monitoring's about, they're very passionate about it. We monitor all these things in theatre. We monitor heart rate, we monitor temperature, we monitor pulse oximetry, but we don't monitor blood pressure continually. And we're trying to drive some change in this. So let's go to Washington. We're going to have a briefing on Capitol Hill, bipartisan. So Democrats and Republicans sponsoring it. We'll get the life sciences industry in as well. And it's just to set the stage and get this message moving forward that we need to, or we should be, increasing the amount of continuous blood pressure monitoring that we're offering to our patients.
Well, I can see why the big industry partners are keen to push the sort of vision forwards. Obviously, they're selling this sort of equipment to us. But you mentioned that this was a patient safety federation involvement in that as well. What was their driver for this meeting?
So it was partly sponsored by the Anesthesia Patient Safety Foundation, so part of the American Society of Anesthesiologists. So they're driving or they're advocating for programs that they think will be benefits to patients, not just on an American, US level, but globally. And they released a statement about a year ago, maybe less, back end of 24, and it was looking at hemodynamic instability. And they had a number of recommendations, but one of that was to increase the amount of continuous monitoring that we use on our patients. And that could be invasive or non-invasive. They didn't specify specifically. I think there's a number of drivers behind that from a patient safety perspective. There is a huge volume of surgery globally, so 300 million procedures plus per year. And only a very, very small amount of that is performed in developing countries. It's mostly westernized Europe. We know that there are very strong associations with hypotension and patient outcomes. And those outcomes are multifactorial. They could be kidney injury, delirium, death. And I freely admit they are associations. There's not particularly robust randomized controlled trials. I doubt we'll ever see those. But the numbers in those observational series are now in the many millions. And we know that roughly a third of patients having surgery have some level of hypotension that is associated with harm. So you take that 1/3 of patients, multiply it by 300 million patients, and all of a sudden you've got a lot of patients being exposed to risk. And so from a patient safety perspective, that's potentially a bit of a public health crisis. And we don't see the injury straight away. It goes on for decades into chronic renal injury, into long-term health conditions. So if we can avoid it, it seems to be a pretty positive step forward.
Where are we drawing the line in this? What is hypotension? What is normal tension? I mean, is that even an important question in this, or am I looking at it too simplistically?
I guess it is a really good question, and it's one I can't answer. I don't know what the answer is. Guess it depends whether we look at a population level or an individual level. If we look at population epidemiology, then it probably is less than 65 is probably our treatment threshold.
As in mean arterial pressure?
Mean arterial pressure, yeah. So 65 millimeters of mercury, mean arterial pressure. And if at a population level, because there is so much hypertension, we aimed for that, we'd probably do some patient benefit. If I ask what's normal for me and normal for you, I don't know. I don't know what the answer is. I think that the threshold, the bottom line is 65. That is probably walking at the edge of the cliff for quite a lot of people. And you probably want to be on the footpath a bit more to the left, maybe 65, 70, 75 for individuals. And it's not blood pressure per se, it's instability is what we're really interested in. So if you have enough activations of your central compensatory mechanisms, that's instability and probably not great for that individual. So population-wise, I think it's relatively well defined. It caveats number of fours, but it has to be individualized at some point.
Great answer. So I guess we should find out what you discussed at this meeting.
Yeah, it's a very interesting meeting. It lasts for about an hour or so. And you wander into the Capitol buildings and you get frisked and go through security. You wander around. I think the thing I didn't realize was how big Capitol Hill actually is. And eventually you wander past the various canteens and you find this giant room. And there's the representatives from the life science industry. There's a clinician there, a doctor called Megan McCleary, wonderful obstetrician and surgeon, and she's been advocating this monitoring for a while, and representatives of the Anaesthesia Patient Safety Foundation. And it starts off with a briefing from congressmen and women about their experience, what they think is important, and then went on. Monty talked about innovation and technology and the industry's perspective. And one of the great barriers to, I think, if we all had the choice, we'd all have continuous monitoring for our patients in terms of blood pressure.
And just to really drill down to that point first, it might sound a silly question, but what are we meaning by continuous monitoring? So is there very frequent monitoring or infrequent monitoring?
Didn't really clarify that very well. So if we talk about our standard of care at the moment, it's just the oscillometric blood pressure, so oscillometry, and depending which society you go to, we're supposed to take it every 3 to 5 minutes. And we know that non-invasive cuffs, they miss a lot of hypertension because it's between cycling or it's then a low blood pressure and it recycles. And we know they misclassify blood pressure in about 50% of the time, either too high or too low. It could be either direction. Well, we have continuous monitoring, and most of us, or all our anesthesia audience, will be familiar with arterial lines. So a catheter we place into the artery, we get beat blood pressure. But technology has advanced over the years. Well, it's not over the years, it's decades old. Continuous finger measurements, so the finger press, I mean, that was described by Jan Panaz back in the early 70s. And I think he presented it at a Czech physics conference for the first time it was there. So we've had continuous monitoring taken from a cuff on a finger for over, 5, 6, 7 decades now. But what has changed is technology has advanced, it's become more usable, more reliable, and we now have various equipments, and not just from BD, but other companies as well. They can take a small cuff that goes around the middle phalanx of a finger, and from that you can get essentially an arterial waveform trace, and from that trace you can derive blood pressure or the measurements of your hemodynamics. And so the drive is to make this continuous blood pressure accessible to those who may be at risk of hypotension, with the premise that if we can avoid it, we can avoid harm. And it's not rocket science, we all know this. If we measure blood pressure continuously, we get less hypertension because we treat it. And it's about widening access to this new non-invasive technology that may, in the future, improve the quality of care that we give to patients.
So we'll come back to the meeting in a second then, but let's pick up on this non-invasive technology. So how does that compare to what many of us would call the gold standard, or what we're more used to, the invasive arterial line?
In terms of when you bring a piece of equipment to market, whether it's within the European Union or within the US, there are national standards to which they have to conform to. So I'll probably get this wrong. I think it's a bias of 8 millimeters mercury plus or minus a standard deviation of, I think it's 5 or so. That neck of the woods in terms of figures. So they're all accurate in terms of that. Interestingly, if you go to non-invasive blood pressure cuffs, so the oscillometric, they tend to be some of the most inaccurate measurements we can get compared to that gold standard if we compare it to arterial lines. So it's really interesting technology. It's simple, it's non-invasive, it doesn't hurt or harm the patient. You can pop it on the same as a pulse oximeter and have beat-to-beat blood pressure. So It's a really great idea. I think we should be measuring it continuously, but it has cost implications. We can't use it on everyone. And it's very interesting from the life sciences industry perspective. They were on the panel, they were discussing, quite openly the cost of this technology. It takes them tens of millions, if not more, to develop it, to bring it to market. And they're very open. Yes, it comes with a price implication. But just like pulse oximetry 50, 60 years ago, when its use was mandated, it was very, very expensive. Because more and more people started using it, the cost started to drop. And that's what will happen with this kind of technology, that it is expensive at the moment. It does have price implications. But if we can engage with life sciences, if we can use it more in the right situation, we will see that cost drop eventually. But ultimately, it's going to require leverage at a fundamental level to say this is the right thing to do. And that's being supported and advocated by patient safety foundations to get them engaged in this and get them seeing it as a positive move forward. And in the initial stages, provide some financial support or incentive to either the life science industry or to the end users, the hospitals and patients.
Yeah, I don't know what the right phrase to use for this is. I hesitate to call it the low-hanging fruit, but where's the most likely situations or where we can make the biggest difference with this to start with?
I mean, that's a great question. And it depends on what we're interested in. We're interested in both, which is patient outcomes and patient experience. We can identify patients who are at risk of hypertension. We can identify patients who are at risk of kidney injury. And we know the longer the surgery, the more likely you are to accumulate that burden of hypertension that leads to harm. So for me, the slightly lower risk, major abdominal surgery, long procedures, and we see increasing rates of surgery, robotic surgery now as well, is where continuous monitoring, you will, if using a non-invasive cuff, you'd miss lots and lots of episodes, repeated cycling. With continuous cuff, you'll have better control over hemodynamics. And I think that is the area where it may lead to better patient outcomes. There's been some interesting work, and one of the reasons that Megan McCleary was on the panel as an obstetrician, using non-invasive blood finger cuffs in cesarean sections and just managing that blood pressure better, having less hypotension because they're at high risk of it. You had better patient-reported outcome measures, particularly reduced nausea and vomiting. And it's a soft endpoint, but they didn't have a blood pressure cuff on their arm. They could hold the baby quite easily. You had better maternal bonding. And those are the things that matter to patients. So we could advocate it on different levels, patient-centered outcomes and harder outcomes, which is probably the wrong phrase, but the ones that we tend to focus on as anaesthetists and clinicians.
That's fascinating, and I can totally relate and see why, from a patient experience point of view, a newborn baby with a new mum is a fantastic sort of case study for this. Well, I've got to say, I'm a bit surprised if that's what the industry, will they not be off by that a little bit? I mean, from an industry point of view, most industries sort of avoid pregnancy and maternity care, and it comes later down the research pathway because of all the extra legalities and all of that. It's an interesting.
Once they've got a product that is regulated and approved, you can apply it to different patient populations. But I think industry is understanding more and more that it's a large driver in what's adopted is patient experience. Patients rightly should be driving what the healthcare system provides for them because they're the end user and ultimately pay for it through taxes.
Yeah.
And so it's identifying what's important to them and then coming up with solutions that resolve those outcomes. So I think it's a natural progression. I mean, there's also now branching out interest into, pediatrics and neonates, etc., which is a minefield to regulatory complications. But pregnant women, they're young, they're fit, they're healthy, they come in. And what I didn't realize, and one thing I learned, the US has the worst maternal mortality in Westernized Europe by a considerable amount. And there are, marked social economic differences, disparities. There are marked racial disparities within the country as well. But it has the worst maternal outcomes. And I was utterly surprised about that.
Astounding. I should say, just to qualify what I just asked you about, that's definitely not me saying we shouldn't be targeting it in these groups. I think, if anything, the good thing, if we can bring some of these products into what are, I guess, more traditionally under-researched or less able to access new interventions, I think that's fantastic. But it's a really interesting model if we can do that with this new technology and target those groups first. I think that's really positive and to be encouraged.
I think it is. I mean, you and I are both researchers, and thought of researching an obstetric population makes you shudder, doesn't it?
Yeah. And it's
like
a shame because it shouldn't be. And I think It's a shame that in those populations, some of these novel interventions therefore take longer to find traction.
Yeah.
It'd be amazing if this could be the other way around and go into those first.
It's also an inherent bias towards them. You don't want to put arterial lines in them. You have a much, much higher threshold to do it. So if you were having your colectomy and you had a bit of ischemic heart disease or other comorbidities, then you wouldn't think twice about it. But we inherently don't want to do it in that pregnant population. We didn't classify it as an operation per se, do we? Or a procedure. It's a mum having a baby. So I think we don't always provide, and not intentionally, we don't always provide the optimal care. We have that inherent bias towards them that they're fit and well and they're going home soon.
Yeah. So go on, let's get back to the meeting then. So what was discussed? What were the outcomes? What did you decide?
So as in all political discussions, nothing was decided. I think that's always the end point there. The meeting was to frame the problem both for the Congress people who were supporting it, and there were lots of interns and other politically motivated people within that environment as well. The meeting was as a springboard to push this project off, to advocate for increased monitoring in terms of continuous blood pressure in the wider surgical population. The meeting really just framed the problem in terms of things we've discussed, the volume of surgery, the amount of hypertension, the harm that comes to it. Provide a potential solution, which is increased monitoring, and there's now the non-invasive options to do that. And then that clinical perspective of how it can be used and how we perceive benefits from it as well. And as with all political meetings, the really good stuff goes on in the background afterwards, where you have those chats and then you start to use those to leverage the momentum moving forward.
And you mentioned this took place in the United States. Are there any similar movements like to occur in Europe and Australasia, or is this truly an international thing from that one meeting, or is it going to take time for that sort of to ripple through to other markets and other environments?
I think it will take time to ripple through. But if we see an increased movement within the US, then it almost always has a knock-on effect in terms of guidance, and they're very good at generating outcomes and quality metrics. I mean, it's a bit reversed. A lot of the goal-directed fluid therapy literature really, and a lot of the evidence on invasive and non-invasive monitoring really comes from the Europeans, and then the Americans pick that up and use that to formulate their guidelines. I think what we will see is this will gain traction and leverage. It will fall into the patient safety sphere within the UK and Europe as the message grows. So I would hope within the next, progress is often glacial, the next year or two, we'll be seeing increasing application for more continuous monitoring, both from life sciences, from governmental institutes, and from the patient safety foundations as well.
Fantastic. I mean, it sounds an amazing thing to have been involved in. Really exciting time.
Yeah, and just really interesting to see the process that kickstarts what hopefully will become a global initiative, but certainly will become a major initiative on a US scale and will drift to other countries and continents around the world.
Brilliant. Well, we'll watch with excitement as it hopefully develops at pace. What's next for you on the horizon? What are you working on at the moment?
Well, at the moment, we're doing a bit of cytokine, chemokine work in exercise and surgery. We just have a RFPB to look at continuous monitoring in elderly neck of femur fractures. So look out for the careful study that was coming your way at some point. It's going to do a feasibility and then upscale that hopefully later on. And the usual mix of 50-50 job worth both 160%, which I'm sure you're well aware of.
Excellent. Well, good luck with that grant. Good luck with the rest of the work. And thank you, as always, for giving it time and coming to talk to us here on Top Med Talk.
Always a pleasure. Thanks a lot. And great to meet you finally, Andy.
And you, thank you. As always, you can hear this and other episodes online through your podcast of choice, whether that's Spotify, iTunes, or the others. Top Med Talk is on social media. That's through LinkedIn, through Instagram, through Facebook, through Blue Sky, you name it, we're there. If you find us on there, do hit like, do give us a subscribe. It really, really does make a difference. And as always, thank you to our fantastic sponsors, which this year are GE and BD, without whom we couldn't keep bringing Top Med Talk free and open access around the world. Thank you.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.